Take the class on CT scan PNS.
Good afternoon. Are you tired? I'm sure you are all tired. So CT scan is a very important aspect of our clinical learning and also for exam, because there is a station for CT scan where you have to score rightly. Now when we image the paranasal sinuses, the traditional image that we have learned during our training was plain radiograph. Why have we drifted from plain radiograph to CT scan gradually? The reasons. What are the disadvantages of plain radiograph? Anyone? Action. কেউ বলতে পারবেন? Anybody?
Is not very clear.
So we cannot understand the details of the paranasal sinuses distribution, and paranasal sinuses are not like two maxillary and little bit of ethmoid and two frontal and sphenoid. So they are so much complicated thing. That is why CT scan is mandatory for diagnosing all the paranasal sinuses diseases, be it inflammatory, be it tumor. The next question is MRI. When do we do MRI? We will talk about that. So first of all, if one person can answer me, if you want to ask for a CT scan of PNS for a person, what are you going to ask the radiologist? What information do you want? Action. Anyone?
Triplanar 1 mm cut.
Okay.
The triplanar and one coronal,
Triplanar, which
sagittal
means
and axial.
mainly scan is taken in axial
Sagittal,
plane,
axial
and
and
there is
coronal
coronal and sagittal
with a
reconstruction.
with a
So
1
you
mm
need
cut.
to see the structures in every plane. Number one. Number two, what
With the
more?
1 mm cuts.
1 millimeter cuts, because there are structures which are slight 1 or 2 millimeter apart, and they can have a significant importance in pathology and surgery. If you take wider cuts, you may miss lot of pathologies. Number three, one more point you need to know. When you order a CT scan, window setting. What is window setting? Because there are CT scan, for example, here you can see, here you can see that these are the coronal section, these are the axial section and sagittal reconstruction. Now I am coming to window. Why do we do CT? Again, it's a surgical roadmap. We diagnose the pathology, identify disease extent, and mainly we want to be alarmed about the variation in anatomy and alarm signs, like because the nose and paranasal sinuses, they are very close to the brain and orbit and various vital structures like carotid and cavernous. So therefore, when we do surgery, when we assess a disease, we need to know how far we are or how close we are to this vital structure to be able to perform safe yet complete surgery. That is important. And so that's like a roadmap. Now what to look for? First is window settings. Sections we have discussed. The CT scan is done and interpreted in different window setting. It's called Hounsfield unit, Hounsfield window. And if you have a smaller, lower Hounsfield unit, for example 100, 125, 200, like that, that will show better delineation of the soft tissue. And if you have a higher Hounsfield unit resolution, so the scans are taken in both soft tissue and bone window, which means changing the Hounsfield unit. So you may not be able to see the character of an optic nerve or structure of an optic nerve in a CT scan if you are seeing the bone window. If you are seeing the soft tissue window, which is taken in lower setting, so when you read a CT scan, there is always written in the lower part W. It will be either 100, 200 or 2000, 2100, which means 2000 and closer to 2000 are going to give you better bony delineation, like integration of the bone, demineralization of the bone, erosion of the bone, and the soft tissue structure like hyperdensities, heterogeneity, homogeneity, all these things will be depicted better in lower Hounsfield unit up to 100, 200, like that. So that is important. And you also need to know the degree of bone destruction, and you also need to understand whether there is bone destruction extending the disease beyond the sinuses or whether there is bony expansion. We know there is a very classical disease called allergic fungal rhinosinusitis, AFRS. AFRS, we do not have bone destruction by the disease, but because of compression, we have bony expansion. We will talk about those things later. And we also should know the limitations of the CT scan, which we will talk about it. So what are the things that we look in general when we start seeing a CT scan? First is pneumatization of the sinuses. One side frontal sinus may be agenetic. One side sphenoid sinus may be little small, one side may be large. Maxillary sinus are generally symmetrical, and ethmoidal disease. Then the most important and key things as you start seeing your CT scan are middle turbinate and uncinate process attachment, because that gives you first impression about the anterior group of sinuses drainage pathway like the infundibulum, and also the relationship to the skull base, how risky the disease and how risky the surgery is going to be as you do the surgery. Also relationship of the anterior ethmoidal artery, because anterior ethmoidal artery is a major disastrous complication if you breach it during the surgery. Frontal recess, lamina papyracea, sphenoid sinus, and optic nerve and skull. So these are the basic schema of checklist as you start seeing your CT scan. Now we'll go to some scans, and here I have shown you that this soft tissue scan, as you can see, we can see the brain structure better. All the structures here are seen in a different resolution, but this is a bone window. You can see the thin bone here. So that's about the Hounsfield unit, which you have already talked about. Now in the coronal section, I'll go through a small whole film, but what you need to do initially, start from the frontal sinus, go toward the mid coronal section, which will show you the middle turbinate, the bit of maxillary sinus, bit of the anterior ethmoidal sinus, the skull base, the medial lamella, lateral lamella, and also posterior group of the area where you will see the full sinus, and also the posterior group of sinus, even the sphenoid sinus, which is like here. As you go further posteriorly, you will see the sphenoid sinus. Now we'll go to a serial scan. This is the first scan. Now can anyone tell me what are you going to see in the first coronal sections? What are the things that you look for? We can see the nasal bone here. Initial scans, what do you see? Anyone? Mike, anybody? These are very basic, I am not asking you anything abnormal. In the exam you have to answer these questions. মাইকটা কোথায় গেল? কেউ বলবে? না আমি বলবো। হ্যাঁ?
Nasal bone septum.
Okay, nasal bone,
Piriform fossa.
septum, piriform aperture.
Aperture. Then frontal sinus.
Sinus appearing.
Yes.
This is the nasal septum, nasal bones, frontal process of maxilla,
Frontal nasal process.
and more of frontal sinus as you keep going anterior to posterior. But that does not show us the frontal recess. And our main importance to understand is the frontal recess when we assess chronic inflammatory disease. So here gradually we are going coronal, and I always prefer to see the coronal first. It's up to you to decide which one you want to see, but we as a I think that my brain can think coronally. As I am seeing, I have read the anatomy like that, and I think that if I have to understand axial, my brain has to reconstruct. So coronal is like what we see. I am seeing your face, I can easily see the coronal section. So see the coronal section first, find out whether it's soft tissue window, round bone window, and then go to axial and sagittal scan. That will give you a complete overview of a good scan reading. So gradually we can see the frontal sinus is appearing, and as we go further, we can see the maxillary sinus appearing. এটা এখানে করলে বোধহয় better হবে. Okay. So now we have come to a mid-coronal section, and we can see the crista galli. We can see the middle turbinate appearing here. We can see the inferior turbinate very clearly. We can see the septum. We can see the maxillary sinus appearing, and we can also see the anterior group of ethmoidal sinus. And now we cannot see the frontal, because frontal sinus is anterior to the middle turbinate attachment and to the osteometal complex area. So you have to also, this is also important to understand during your surgery and practice, that frontal sinus is not going like this. It's like this, and it comes to the front. So then we would go further posterior to see the attachment of the middle turbinate, and this is the first part of the middle turbinate. Can anyone tell me what are the attachments of the middle turbinate? 3 parts. Then only we can read the scan better. क्या बोलबे ना? Yes. Middle turbinate has 3 parts.
So, anteriorly it is attached to the skull base.
Yeah, we can see
above,
that.
And in the middle portion of the middle turbinate it is attached lateral to the lamina papyracea. And in the posterior portion it is attached to the vertical plate of the palatine bone, sir.
Okay. So essentially the middle turbinate, as we read the coronal scan, middle turbinate is the most important landmark for us to first read, because as long as we are seeing the vertical attachment of the middle turbinate to the skull base, we know we are in the region of the anterior part of the osteometal complex and also the anterior group of ethmoidal sinus. As we see the middle turbinate turning slightly laterally towards the lamina papyracea, we know we are, because as we know, second part of the middle turbinate or the ground lamella is the transition between anterior and posterior ethmoid. Because otherwise, if you do not have a landmark, how would you know if a disease or anything is lodged in the anterior ethmoid or posterior ethmoid? So that middle turbinate gives you an idea about where it is lodged. So you can see the middle turbinate is, maxillary sinus is getting wider and wider as we go further in the scan. I do not know why this movement is happening. We can gradually see the middle turbinate is turning laterally. There. This is the middle turbinate. Now it is turning laterally towards the eye. So this is actually the second part of the middle turbinate, and we are actually seeing still the anterior ethmoidal cells and the transition between the anterior and posterior ethmoidal cell. In addition, not only sinuses, we also look at the turbinates, because the turbinates, as we look at the sinus scan, we also need to keep an eye on the posterior part of the nasal cavity. There may be a tumor here in the posterior part of the nasal cavity, which if you are just focusing on the sinuses, you will miss. So you need to see what is the character of the turbinate, and we know there is a smooth transition of this hypertrophic turbinate versus a normal turbinate on this inferior turbinate. And also, as we keep on going, we will also see the bone here, the orbital lamina, which is intact. Of course, this is a normal scan, there is no disease here. And as we go further, we can actually see that the middle turbinate is completely horizontally attached, which means we have now gone and we are looking at the posterior ethmoidal cells here. Okay, and we are also going towards the posterior part of the globe. Further, if I go, I will see the nasopharynx. This is some pneumatization of the septum, which we will talk about later. We have now entered the sphenoid sinus here. I will also talk about all the sinuses separately, but this is just an overview. And we now need to look at the end of nasal septum, which means we will now land into nasopharynx. And therefore, we start seeing the nasopharyngeal structure. So sphenoid sinus, there is a septum in the sphenoid sinus, as you can see, and the nasal septum is still there, which means we are still in the nasal cavity. The inferior turbinate is not there. These are probably superior turbinates. As we go further posteriorly, now the nasal septum is not there, which means we have just crossed the posterior choana and we have landed into the nasopharynx. And if there is a mass in the nasopharynx or a hypertrophied adenoidal tissue, grossly hypertrophied, this is the scan where you will see that in the transition from choana to the nasopharyngeal posterior wall. And these are the various intricacies of sphenoid sinus, which we will talk later on. Now you also see the medial and lateral pterygoid plates here, which is very important for assessing a tumor when you have a tumor in the posterior part of the nasal cavity, especially juvenile nasopharyngeal angiofibroma or a fungal disease which happened during the COVID pandemic. This is very important to understand the medial and lateral pterygoid plate and subsequent infratemporal fossa. So we are coming to the end of the sphenoid sinus here, and the nasopharynx is completely clear, and we have, this is the oral cavity and oropharynx. So that's end of the coronal section. What are the things to focus on? As we have said, first of all, attachment of the middle turbinate, which may not be mirror image on either side, as you can see here. This is small here, so the attachment may not be same. You also assess the crista galli, cribriform plate, medial lamella, lateral lamella, roof of the ethmoid, and the lamina papyracea here. Subsequently, you go to this scan where you can see the this is the basal lamella, transition from anterior to posterior ethmoid, and also the opening here, which is nothing but the natural ostium of the maxillary sinus. I will also show you how to assess the accessory ostium. And then this is nothing extra in that scan. Now, what are the variants of middle turbinate? We have said that middle turbinate hangs from the top. The first variant is concha bullosa. The second variant is this is a interlamellar cell. On same patients may have different variety. You also have a paradoxical middle turbinate, which is nothing but the middle turbinate is in opposite convexity, causing obstruction. This convexity will cause obstruction to the osteometal complex. You can also have something called turbinate sinus. What is the implication of turbinate sinus? You have to actually resect that portion of the turbinate, because otherwise that will act as a nidus or focus of infection even after a very successful surgery. So, and this is interlamellar cell of Granwald, which pneumatizes from the ethmoid sinus into the middle turbinate. Also here you can see. So these are the common variants you can see, and you need to identify the variants both for your clinical judgment and also for your exam purpose. Now, what is the uncinate process? Because we need to understand osteometal complex is blocked or not in a chronic inflammatory sinus disease. How would you understand? Even if there is no disease in the sinuses here, these are the two uncinate process here, and this place is infundibulum, this is bulla. So we all understand that between the bulla and the uncinate process is the hiatus semilunaris inferioris and the infundibulum. So it is the hiatus here, and the infundibulum is this one, which is draining the anterior group of ethmoid sinus and the maxillary sinus. And therefore, we need to understand the osteometal complex and the attachment of the uncinate process, which can be, uncinate process can be medially or laterally rotated. As you can see, the uncinate process here, this is quite a wide infundibulum, but because of this concha bullosa, the anatomy in this region is distorted. So same thing you will expect to find as you do the surgery, that this will be a textbook osteometal complex and this side will not be a textbook complex. This is again uncinate process which can be fenestrated. Again, it doesn't have much importance, but if it's fenestrated, it's going to be very bulky. Now, what is the importance of understanding this? The uncinate process here is very normal, as we said in the other scan, and the infundibulum is very wide. Here the uncinate process is lateralized and touching the lamina papyracea. এটাতে কি প্রবলেম হতে পারে ফেস করলে?
When we are trying to break the uncinate, if we go up to the upper attachment, then all
so
vital
if you do not
complications
assess this during your CT scan, the moment you are doing uncinectomy, you may land up into the orbit in this particular case. Here there is wide infundibulum, you have enough space for instruments to work, and therefore uncinate processor position ta bojhata very important in chronic inflammatory diseases. Next, you can also see the accessory ostium, which is not seen in very routine scan but very good quality scan. You will see the difference is here the uncinate process is here attached to this area above the middle turbinate, because as we know, uncinate process horizontal path attached to the middle inferior turbinate, sorry. If you go to this scan, we can see this part is not attached, and these two gaps here because they are not typical uncinate-like attachment. They are the accessory ostium, which are nothing but a opening in the lateral wall of the nasal sinus. So these minute things will not be visible if you do a 5 millimeter scan. If you do 1 millimeter scan, then you will be able to see these things. You can also have Heller cell, which is nothing but Heller cell ta ki? Maxillary sinus. So essentially it is also a ethmoid sinus cell which has pneumatized into the maxillary sinus roof or floor of the orbit. So what is the implication again? If you do a middle metal enterostomy, you may straight away go into the Heller cell, and from there, if you think that is the maxillary sinus, you will go to the orbit straight away. So that is why you need to identify the Heller cell in the scan. Next is assessing the olfactory fossa. Again, এখানে তো সব দেয়া আছে, but can anyone tell me what is the implication of understanding the depth of the olfactory fossa? কেউ বলবে?
Sir, it helps us to be precautious during surgery, because while doing ethmoidectomy, we can accidentally damage the skull base if the depth of the olfactory fossa is less.
Absolutely. So it is the distance of this depth, because you see, this is the medial lamella of the cribriform plate and this is the lateral lamella. More clearly seen, this is medial lamella, this is lateral lamella. And you can see this bone is so thin because it's cribriform plate part, and this is the frontal bone. So roof of the ethmoid actually has the fovea has the medial part very thin, which is formed by the cribriform plate lateral lamella, and the lateral part very thick, which is the frontal bone. Now if you have a olfactory fossa which is type 1, which is 1 to 3 millimeter depth here, when you are working in the ethmoid, you are working in an ethmoid where the most of the roof is frontal bone, very thick. So your chance of penetrating into the skull base is very rare. But if you are working in a type 3 type of situation, the anterior ethmoidal cavity or ethmoidal sinus roof and this wall is actually very thin here, and a major part of this. So while a surgeon is doing the surgery and with the forceps, you can easily go into the skull base while you are not poking here, you are just going paraseptally here. So that is important to understand, and that's why you need to see this also in the coronal scan. Anterior ethmoidal artery. What is this called? Kennedy's nipple. And what is the implication of finding the anterior ethmoidal artery? Anterior ethmoidal artery to skull base এখান থেকে যায় রুফের ভেতরে বোনের মধ্যে থাকে. What is the problem? So a significant percentage, up to 40% patient, it can lie without a bony covering, and then if we puncture it, একজন বলবে কি প্রবলেম হবে? মাইকটা দাও, কে বলছে?
So there will be retroorbital hemorrhage will result, following which there may be optic nerve
But why not epistaxis? Why retroorbital hemorrhage?
Because it retracts. If it's not, it immediately retracts into the orbit.
It retracts into the orbit. So it is a surgical emergency if you puncture the anterior ethmoidal artery, and if you are well prepared with your armamentarium, you can diathermize it. That's fine. But if you fumble and if you take time, it will retract, and a retroorbital hematoma can jeopardize the hearing by exerting pressure on the optic nerve. So that's a surgical emergency, and that's why this is a area. So if you look at coronal scan, you look for this Kennedy's nipple. When you see this nipple, you know this is the area, and this is one situation where you can see the artery is lying absolutely empty, and these are the cases where you have to be very careful. Coming to frontal sinus drainage pathway. What is the specialty of frontal sinus? One thing I would like to tell, that when we read our anatomy in our MBBS postgraduate, we read about a frontonasal duct. Like frontal sinus drains into the nasal cavity with a so-called duct. But actually renewed endoscopic anatomy has taught us that no duct exists. It is a recess where the frontal sinus collection comes and drains into the infundibulum, and that recess architecture and the wideness or narrowness is decided by multiple factors. কে বলতে পারবে? What decides the architecture of frontal sinus, narrow হবে না wide হবে? বলো।
So it depends on the thickness of the frontal beak.
হ্যাঁ,
Upon the numerization of the Agarnesi cell, the thickness of the frontal beak, and the type of Kuhn classification of frontal cells that we have.
so essentially আর কিছু? Yes, another vital point, attachment of uncinate. So the attachment of uncinate process, attachment of the pneumatization of frontal, various types of frontal cells, and the size of frontal beak. All these things will govern how bad the frontal sinus is going to be in terms of drainage. Now the drainage pathway, for example here in this coronal scan, we can see the frontal sinus is draining here lateral to the middle turbinate. But if the middle turbinate is attached into the lamina papyracea here, then the frontal sinus will drain medial to the lateral. So that is also a very important factor for us to understand before we embark on surgery. So whether the frontal sinus drainage pathway is medial or lateral, and then we decide on the configuration of the sinus pathway by looking at the cells. For example, these are two cells here. Probably I'll show you the diagrammatic picture first. Kuhn cells. Anybody can tell me from this side? Mike, what are the different types of Kuhn cells? Very important for us to know. Anybody?
So single cell above the Agarnesi cell, two or more cells above the Agarnesi but not reaching the frontal isthmus, one single cell less than 50% height, vertical height of the frontal sinus, and one cell more than 50% height of the frontal sinus.
So this is
Vertical
2.
height. Huh?
2, 3. What is 4?
And fourth is more than 50% height.
So this picture is showing us, this is one cell above the Agarnesi, this is 2, this is 3, and you can also have a separate lonar cell. So this Kuhn cell can be best assessed in the coronal section, and we will also need the sagittal section for frontal sinus. I am coming to that. So these cells, basically when we do frontal sinus surgery, we just have to deal with the cell, because frontal sinus ostium is about 2 millimeter diameter. So we if we touch the mucosa of the ostium and curate the mucosa like we ruthlessly do in maxillary sinus, we can cause iatrogenic frontal sinusitis. Therefore these cells have to be studied, and we can then remove the disease. We have to do a submucous decompression of the cells, therefore opening the frontal recess. Okay, and this is the lateral scan, sagittal scan, which shows us the frontal beak. Here there is a better picture for a frontal beak. You can also have frontal bular cell. This is the frontal bulla, ethmoidal bulla, sorry. You have a suprabular cell, you have also frontal bular cell, which are in the posterior wall. So there can be cell in the lateral wall, anterior, in the anterior direction above the Agarnesi, which blocks the frontal recess. There can be cells in the posterior wall, which are called the frontal bular cell, which are nothing but, it basically from bulla ethmoidalis they go, actually if you see the bulla ethmoidalis in life, bulla ethmoidalis, roof of the bulla forms the floor of the frontal sinus or frontal recess, not sinus. So if there are pneumatization of cell above the bulla, those are called the frontal bular cell or suprabular cell. Suprabular means behind the front, below the frontal sinus. Frontal bular means it goes into the, towards the frontal recess and towards the frontal sinus. And laterally we have the Agarnesi, 1, 2, 3, 4. So all these cells you have to read properly before you embark on frontal sinus surgery. And attachment of the uncinate process, like he said, medial or lateral, that will decide whether the frontal sinus pathway is medial or lateral. So these are the cells. I am not going to go into the details here. This is the beak here, frontal beak, which will also govern the structure of the frontal recess. Again here, this is the frontal beak and this is the sinus. These are the anterior group of cell here, and there are some posterior group of cell here. These are the agarnezy and subsequent type 1, type 2, type 3 cells. So that is why sagittal section is required to understand the frontal recess anatomy. We will leave that. So if we start again like we did that coronal section sequentially, this is the mid coronal section from where you can see the frontal recess. These are the cells, agarnezy, one cell above it. The frontal sinus is not appearing yet. This is the medial lamella of the cribriform plate. This is the lateral lamella, and then as you go further, you are seeing the frontal recess as a whole, and subsequently if you go further, you will see the frontal sinus anatomy. And that's how, after doing the initial evaluation of the coronal scan, it's like scanning what is there, what is gross there, and wherever there is disease, you go back thoroughly, and when you assess frontal recess, you go from posterior to anterior. Initially you have done an anterior to posterior scanning, which is like just like a scanning. এখানে এসে দেখলাম কি চলছে, কোথায় কে বসে আছে, দেখলাম এখানে একটা গন্ডগোল আছে, then I go there, and then for frontal recess, posterior to anterior যদি coronal scan গুলো দেখি, I can understand the anatomy, followed by the sagittal, because then I will see the posterior group of cell also. Okay, so very important. Ethmoid sinus I think we have discussed. Sphenoid sinus again very important. আমি একটা ছবি আছে এখানে দেখো. Once you understand why sphenoid sinus anatomy is so important, you can see the sphenoid sinus has relation with the optic nerve. It has got internal carotid artery. It has got the foramen rotundum here. It can be highly pneumatized where it creates a lateral recess where the disease can be lost, especially fungal disease. Allergic fungal sinusitis is a disease where you are not doing a radical surgery. You are doing a mucosa preserving, fungal debris clearing, ventilation clearing surgery. But if you have a lateral recess where there is fungal debris, it is extremely difficult to take out. So that is why your entire surgery success can be falling apart if you leave disease here. Disease means fungal debris. Polyp is not a major disease. Polyp will be resolved when you do intranasal steroid and douche and all. But if you leave fungal debris, and this is one area, just like sinus tympanoite cholesteatoma থেকে যায়, এইখানে ফাঙ্গাসের ডেব্রি থেকে যায়, which can lead to a early recurrence. So এই জিনিসটা lateral recess আছে কিনা বোঝাটা খুব important. And also we have the median nerve here, which is important for JNA, because in JNA we have to go right up to the median nerve and drill out the median canal, because it is now believed that median canal has strong attachment of the JNA. So that is important. And the frontal sinus anatomy can be very much variable. The septum can be in the midline, it can be on one side, it can be everything. One more important thing, there can be septa in the front, the sphenoid sinus, which is attached to the internal carotid artery. And therefore, if you are doing any surgery in the sphenoid sinus, if you just bite a septa which is attached to internal carotid, you can cause a lesion of the internal carotid artery and life-threatening bleeding. So that is why you need to read the anatomy very well, and these are the area of the optic nerve which I have shown you. Coming to axial scan, কম সময়ের মধ্যে এর বেশি বলা যাবে না, আমি চট করে এটা শেষ করে দিচ্ছি। Axial scan again overview. We need to understand axial scan এ কি information আমরা পেতে চাই. Like we have said in coronal, axial scan এ primary key information হচ্ছে if there is a maxillary sinus disease টা anteriorly আছে না posteriorly আছে, how close to the ostium, how bad, and if there is a tumor like inverted papilloma, where is the attachment of the root attachment of the inverted papilloma. These are the very key information that we need, number one. Number two, we need the relationship of the sphenoethmoid. Sphenoid of the একটা disease গেছে যায়নি, and what is the extent of disease from ethmoid to the sphenoid. Next হচ্ছে relationship of the lamina papyracea and the orbital content with the ethmoid and sphenoid sinus. These are the very few important things in addition to many other things that you need to first focus as you see scan. একটা স্ক্যান দেখলে তো আমরা আধা ঘন্টা ধরে স্ক্যান দেখার টাইম পাই না, সো উই শুড হ্যাভ এ স্কিমা ইন আওয়ার মাইন্ড যে প্রথমে আমরা এই রিভিউ করব, ইম্পর্টেন্ট এরিয়া এটা এটা দেখবো, অ্যাক্সিয়ালে আমি বললাম কি কি দেখতে হবে, কোরোনালে অ্যাক্সিয়ালে উই নিড টু লুক অ্যাট দিস স্ক্যান। ফর এক্সাম্পল এখানে অনেক কিছু আমরা দেখছি লাইক ম্যান্ডিবল, ওরাল ক্যাভিটি, ওরোফ্যারিংস, sinuses are not appearing yet. So maxillary sinus appear, and also you need to see this impacted last molar. Sometimes it is inside the sinus, which can be a cause of a recurrent maxillary sinusitis. The root can be exposed in the maxillary sinus, so that also needs to be seen. And then we see the structure of the maxillary sinus, the wall. If there is pathology, now here you can see all the walls. There you could see the orbital and maxillary sinus relationship. Here you can see all the wall. If there is a breach in the wall and the relationship of the middle turbinate, as we go upwards, gradually we will be able to see the ethmoidal cells here, there, and the sphenoid here. Sphenoid on one side appears to be larger than the other, which is again not uncommon. This is the area which is very important for axial scan, because you can see the entire lamina papyracea here. If there was a disease here, then you could see which part of the lamina papyracea is dehiscent or pressurized. Like for allergic fungal sinusitis, you will see it is pressed here, and you can see the optic nerve, medial rectus muscle, all these structures you can see. And I will go through quickly to again same thing. প্রত্যেকটা স্ক্যান দেখানো সম্ভব না, আমি কয়েকটা ডিজিজ দেখিয়ে দেবো and then we'll finish. Again, as we go higher up, we can see the frontal sinus also, but mainly, as I said, antrum, sphenoethmoidal relationship, optic nerve, etc. Next thing we need to know is an ONOD cell. What is ONOD cell? কে বলবে? এইদিকে পেছনে কেউ বলেনি।
Postero cells extending to sphenoid sinus.
Okay, so it is a posterolateral extension of a posterior ethmoidal cell beyond the confines of the anterior part of the sphenoid sinus. Okay, এই যে anterior ethmoid, posterior ethmoid sinusটা এখানেই শেষ, but this has gone beyond this sphenoid sinus, and here the optic nerve is lying dehiscent. Or so in a coronal scan, when you keep on seeing the ethmoidal sinus and finally go towards the sphenoid sinus, if you see a horizontal septum like this, you suspect that the ethmoidal cells are going beyond the sphenoid sinus, and those are the ONOD cell. And what are the importance? The ONOD cell can house a bare optic nerve, and therefore you can cause damage by disease or by iatrogenic issue. So these are the ONOD cell. Coming to a few pathology, I don't need to discuss this. Is chronic rhinosinusitis, osteometal complex block, mucosal thickening of the maxillary sinus of all the walls. This is more pronounced here. This is isolated, just one scan does not tell you anything, but you can see the enteroconal polyp. This is a case of enteroconal polyp, but if you see subsequent scans in the coronal, you will see that mass is going, is not coming to the anterior part, is going towards the choana, and that would give you a diagnosis of enteroconal polyp, which you can verify in an axial section, which will also show you very clearly that it's coming out of the antrum and going towards the nasopharynx, and it is usually homogeneous, not heterogeneous. Extensive ethmoidal disease, single sinus involved, hyperdensity, heterogeneous opacity, little widening of the osteometal complex, you should suspect a fungal ball. By definition, as you know, one sinus is involved and that hyper density shows fungal ball. AFRS, anybody can tell me, our 5 minute nebo? Anybody can tell me the diagnostic criteria of AFRS? Radiological criteria. Bony expansion, hyperdensity.
Serum eosinophilia and positive fungal smear.
Okay, so she has told us everything.
This is the major criteria.
Major criteria, Bent and Kuhn criteria. But radiologically, we would see heterogeneous opacity, multi-sinus involvement,
And double density
polyposis, hyperdensity or double density, and bony expansion beyond the sinuses. Okay? Expansion but not destruction. Expansion means if there is a destruction, it will be localized. If there is an expansion, there will be generalized expansion of the lamina propria or some other structure. For example, this case, extensive AFRS, you can see. What are the things you can see? Can anybody quickly describe me finding etate? Mic ta niye ekjon keu bole dao. Everyone is hungry, I know, for lunch. Keu bolbe finding? আমি তো ডায়াগনোসিস বলে দিয়েছি। কোন সাইনাসে কি আছে বলো না, একজন বলো কেউ প্লিজ।
It's a coronal section
হ্যাঁ,
showing
সফট টিস্যু উইন্ডো সেটা বলতে হবে।
so it's a soft tissue window
হ্যাঁ, বিকজ সফট টিস্যু ডিলিনিয়েশনটা বোঝা যাচ্ছে।
showing the double density opacity involving both the frontal sinus, more in left, and involving both the anterior ethmoids and
Maxillary
nasal
sinus.
cavity, and with right maxillary cavity.
আর কি আছে?
Left side it's orbital.
So floor of the frontal sinus on the left side is compressed to the orbit. ওকে, এটা অ্যাকচুয়ালি বোন উইন্ডো দেখলে আমরা বুঝতে পারবো যে এটা ইরোশন না ডিমিনারেলাইজেশন। অ্যাকচুয়ালি এএফএস এ কি হয়? ডিমিনারেলাইজেশন। অরবিটাল পেরিওস্টিয়াম will be intact. Okay, and also the roof of the frontal sinus here. So this is a typical neglected AFRS where there is extensive disease. So this case, after you have to ask for a bone window to see whether the lamina propria and everything is okay here, whether the orbital periosteum is intact, whether the dura is intact. If you are in doubt, this is the case where you will ask for an MRI, even for a chronic inflammatory sinus disease, because you want to make sure the dura is intact before you embark on surgery. এইটাতে MRI আমরা চাইবো, হ্যাঁ, to get a more information. Same patient, আরো আমরা দেখছি same patient. This is bone window of the same patient. You can see here we cannot see the disease. Could you understand the difference between soft tissue window and bone window? একই patient, এখানে soft tissue পুরো বুঝতে পারছি, metal dense opacity, hyperdensity দেখছি. Here I can't see anything, as if this is polyp, no hyperdensity, but I can see the bones very clearly. কোথায় কতটুকু break আছে, কোথায় thickened আছে. That is why the bone window has to be red. Again AFRS, এটা আর আমি বলছি না, এটাও বাদ দিচ্ছি। JNA, JNA তে কি কি সাইন পাওয়া যাবে কুইকলি কে বলবে? এনিওয়ান? না আমি বলে দেবো, লাঞ্চ টাইম হয়েছে, আমার দিকে তাকাচ্ছে সবাই।
Sir, Hondusa sign, Holman-Miller sign, and Ramharan sign.
ওকে, সেটা কি ডেসক্রাইব করো।
Holman-Miller is anterior bowing of the posterior wall of maxillary sinus. Ramharan sign is increase distance between the maxillary and the mandibular widening of the pterygoid wedge.
Widening of the
pterygoid
wedge.
wedge. হ্যাঁ,
আর এটা কি সাইন বললে?
এটা রামহারান সাইন।
হ্যাঁ,
আর হন্ডুসা সাইন।
হ্যাঁ,
হন্ডুসা সাইনটা কি ছিল? ওই ইনক্রিজ ম্যাক্সিলারি ম্যান্ডিবুলার ডিসটেন্স যেটা।
ইয়েস। সো এসেনশিয়ালি সাইনগুলো তো পরীক্ষায় জিজ্ঞেস করবেই, but you have to understand that there will be a lesion or a mass in the posterolateral aspect of one-sided nasal cavity যদি ছোট হয়, and from there posterolateral aspect in the region of the spinopalatine foramen the mass will extend and erode possibly the pterygoid plates, medial and lateral. It will enter into the pterygopalatine fossa. it will have a destruction, or I'm saying likely to have everything, destruction of the posterior wall of the maxillary sinus and spread into the infratemporal fossa and beyond to the skull base superorbital fissure. But axial scan এই ছোট JNA টা দেখা যাচ্ছে এখানে, you can see everything is intact here and it has not gone beyond the pterygopalatine fossa here. So this is our earliest and small stage 1 JNA, and you can have JNA like this where it is so obviously you need to check whether this is a contrast scan or not. This এখানে লেভেল করা নেই, এটাতে কন্ট্রাস্ট হয়তো নেই, but if there is no contrast scan you must ask for a contrast scan. So when you read a scan for anything in life, you first should see window setting, then you should see contrast or not. Contrast টা থাকলে লেখা থাকে, because your diagnosis may change depending on whether you are reading a contrast scan and non-contrast scan of the same finding. Okay. Again JNA, all these disease everywhere, pterygoid plates destroyed, medial pterygoid plate, everything is gone, and this is the typical early JNA. From posterior nasal cavity there is widening of the space between the posterior wall of the maxillary sinus, which is still intact, pterygoid wedge going into the pterygopalatine fossa and infratemporal fossa. This is the root of JNA, and superiorly it goes to the superorbital fissure. Inverted papilloma can have anything, but usually have a gross multiple bony erosion kind of situation, but it can be a very small inverted papilloma in the maxillary sinus. It's not very classical, rather the clinical look is classical for. You can also have mucocele. This is another situation. You can see a mucocele here. It can be also a polyp. To verify whether this is a polyp or mucocele, you just have to do an MRI to make sure whether this is fluid density or soft tissue. Then you know it's mucocele. If it's mucocele, the surgery is 5 minutes. If it's a mass in that region, the surgery is 2 hours. So that is the difference in planning. Again, mucocele breaking into the orbit here. Again, you should ask for an MRI to see the orbital content and periosteum. CSF leak, last word. This is the last slide. Whenever you suspect a CSF leak, you should do a CT cysternography, and you can see the cistern CSF signal coming into the nasal cavity. This is the roof skull base. If it is coming paraseptally, you know it's a medial lamellar leak. If it is coming lateral to the middle turbinate, you know it's a lateral lamellar leak into the ethmoid. Okay, is that clear? And that would guide you to do the repair leak. And this is the sphenoid sinus, very rare leak we got in the lateral recess. Very difficult to repair, but you can also get leaks like this. So you have to understand and thoroughly. Sometimes you can get osteoma, which is very easy. You don't need contrast or anything. It just the hyper density localized area tells you that this is an osteoma. And sometimes there is no anatomy. There is previous surgery done, so you have to find out what is there. So read the anatomy. Firstly, bony and soft tissue window is necessary in all sections, and judge the section of a film first, coronal and axial, as I said, and then you read soft tissue or bony window, contrast or non-contrast, because that will change a lot of things. And as I said, scan the entire film first and then come to a particular focus area. Come back to the slices which contains info and study details. Anatomical correlates, like always if there is a disease, correlate with some reference point, and that will give you a good idea about this. And do not spell too much in the exam. This is for exam. Whatever you are asked, you let the examiner ask you, and then scoring will increase. If you just go blah 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 blah, then you may go into the ditch sometime. So let the examiner get chance to assess you and give you marks. Thank you. All the best.
Thank you, sir. Now it will be the lunch break.